All right, so well, I'll just jump right into it. All right, morning, guys, and apologize for the slight delay in starting this. I'm guessing everyone is at home and staying safe. Now, from an Avnrt standpoint, John, I understand that I'll have talked to the students about this. St. Jude has done a presentation on Avnrt.
Jude has done a presentation. Mike has. We've gone over Avnrt, EVRT, and atrial tach this week.
Okay. Okay. So in this talk, what I'll do is, and thank you for sharing these slides again, John and Mike. It saved me a lot of time. So in this, what we'll do is, I'm sure y'all know a lot about Avnrt by by this time. What I will do is I'll share, the theory part of it, if you will, from a physician standpoint, and how we approach Avnrt, and go over not only the mechanism, the pathophysiology, but also the logistics involved in diagnosing and treating Avnrt. And at any point, if anyone has a question, feel free to ask. I'm going to keep this as informal as possible. I don't think we need to wait till the end to take questions. Of course, I'll be happy to do that, but at any point, if there's something on the slide that y'all don't understand, or there's something that that you'll have seen or heard before, and had a question, feel free to ask me at any point. Okay. Before we start, does anyone have any questions or anything specific that that they've not understood, or that they're trying to get out of this presentation? Anyone at all? Okay, cool. All right, so we'll get started. So Avnrt, as you know, it stands for AV nodal reentrant tachycardia. It's one of the most common SVTs, the supraventricular tachycardias that we deal with in the EP lab, and also in our clinical practice. And there'll be some slides that kind of talk about that. This is the first slide I have in my presentation. Basically, it just talks about objectives of this talk, and more importantly, I think it's recognition of the SVT that makes the biggest deal, because I cannot tell you the number of times you've got catheters, and then patients in some kind of tachycardia. It looks like Avnrt, but then it turns out to be something else. Fortunately, it doesn't happen all the time, but when it does happen, then yeah, it's an all-day procedure. It turns out to be a real long day in the EP lab. So, like you said, the first thing we got to understand is, I like doing this for any clinical condition, if you will. Try to understand the definition of a particular condition, because I think that forms the basis of understanding and just moving forward in treating those conditions. So in electrophysiology, as you know, there are three basic mechanisms: the reentry mechanism, the automatic mechanism, and then you have the focal, the triggered automaticity, as they call it, or the focal mechanism. Reentry, fortunately, is something that we see pretty commonly, and I say fortunate because the chances of fixing this, if you will, is much higher than dealing with the other, automatic tachycardias and what have you. So when we say Avnrt, what we're saying is that this is a reentrant mechanism. All EPs, they light up when they hear reentry, and it's within the AV node, and that's something which needs to be understood. And I'll show you more slides as we go forward in this presentation. If I can do that. Okay, there you go. So like I mentioned, it's probably by far the most common SVT that we deal with in the office setting, as well as the EP lab. If you're looking at the slide, it says it accounts for about 60% of the ablations, and to a large extent, I agree to this. But I would say that in today's day and age, with all the diagnostics that we have, it's definitely much higher. Also, realize that this reference is from 1992. So maybe back then it was about 60%, but I would say in today's day and age, it's probably close to about 80%. Now the other 20%, again has changed because, maybe in the 90s it was the ORTs, and maybe the atrial tachycardias, but now because of all the AFib ablations that we do, we see a lot of these left-sided atypical atrial flutters, and that's something we can also talk about at a later date. That's a whole different topic. It is true that women, for some reason, manifest AVNRT, typical AVNRT more than men. Go figure. We've never been able to find why. But more importantly, what I've seen is this the graph in the presenting age. Most typically, we see this in women in about in the 20s, maybe mid to late 20s. And for some reason, if it's missed or it's not as severe at that age, they do well in the 30s, 40s, and then for some reason it comes back in the 50s and 60s. So the peaks, if you will, are in the 20s to 30s. And then we see a lot of patients in the 60s who've never been diagnosed or who've been diagnosed with, anxiety because they're normal and whatnot. No one really goes into the depth of these issues. And again, I've seen multiple patients that have been diagnosed with anxiety. I've been on anxiety pills and turn out to have AVNRT. So remember that it's 20s to 30s, and again, for some reason, in women 50s, 60s, and above, you see them. In fact, I saw this lady who was in her 80s, who actually is in her 80s with typical AVNRT, and she was like, I've had this all my life, but they just caught it now, and she's 84. She's a healthy 84, and she's got typical AVNRT. So when we talk about AVNRT, there's the typical, atypical, and others. Yeah, typical, I would say, is in the range of 90% or more. Atypical, 5 to 10%. The others, you know, again, they've quoted 7 to 10, 13%. I think it's much lower. And there's been a more talk and more recent studies that suggest that even the AVNRTs with a left-sided extension or left-sided input, as they call it, is still considered within the realm of typical AVNRT. It's just anatomically different, and we'll talk about it. So in the next couple of slides, I'm sure by after reviewing those slides, you'll know what the difference between typical and atypical AVNRTs is. And yeah, first let's talk about the triangle of Koch. This is anatomically the most important structure, and a lot of times, in fact, if any one of y'all have scrubbed or watched me doing a AVNRT ablation with my catheters in, I always identify the structures in the triangle of Koch, and that could also be because of my training. Because when I trained, we were not as dependent as we are today on three-dimensional mapping. We used a lot of X-ray. So we actually made an imaginary triangle, if you will, where we would put in catheters, identify the AV node, as you see it here. This is obviously from Catheter. You see the AV node, and then you see the fast and the slow pathways. So if you use the same on the cartoon next to it, kind of gives you a better idea of the AV node, the tendon of Tadaro, the slow and the fast pathways. The reason I do identify the triangle is mainly because, I mean, think about it. These structures are really, really small. There's a reason it's called the compact AV node. And in someone that's, say, 25, pretty healthy and, young, of course, the distance between the compact AV node and, say, the slow pathway is not much. We're talking about, maybe half a centimeter, if you will. The diameter of the catheter is about 4 millimeters. And you also got to realize that this ablation is done in a beating heart. It's not like we stop the heart. The heart is beating at whatever, 60, 70, 80 beats a minute. And some folks who tend to be really anxious, the heart's going 100 beats a minute. So when the heart's kind of going this, the catheter is banging against one part of the heart, and then it tends to move. So if you have the ablator on one area, you call it the sweet spot, say over here, and then the heart's kind of beating, it tends to move, and there's always this chance of causing collateral damage. to the AV node, and that's something we got to be really careful. And you would hear some of us always tell the patient to breathe normal. Of course, you can't tell them to stop breathing, but we say breathe normal, but don't take a deep breath, because guess what? You got the catheter here, the patient takes a deep breath and boom, moves right up here. And unfortunately, that's happened. Those are true horror stories where patients have ended up in heart block just because of that. This actually gives you a better idea of what I was just talking about. So imagine a catheter in the CS, okay, and you've got your bladder, say maybe right about here, and imagine, I mean, the distance between your catheter, which say maybe is here, and the compact AV node, less than just about a centimeter. Right now, it looks like it's miles away because this is a still picture, but imagine in a beating heart. This is a dynamic number. It keeps changing. Oops. So why does Avnrt happen? And again, you guys probably know this. I'm sure Mike and John have been drilling this into your head. And this is the most basic slide that you need to understand for reentry mechanism. So you've got the alpha or the slow pathway, the beta or the fast pathway. Now, I get asked this question a lot in my practice as to why do some people have Avnrt and why do some people don't? The God honest truth is no one knows. We all have slow and fast pathways. Why that accept in some people? Why do some people get Avnrt? Personally, I don't have any answer. And I think, during my training, and I've asked this question to my attending physicians, and I don't think there's any straight answer. So some people call it luck of the draw, call it an an extension, who knows? But the fact is, some people have Avnrt, some people don't. The good news is Avnrt is not a life-threatening, arrhythmia. That being said, if the heart's going at 160, 180, even 200 beats a minute in younger people, for several minutes or even longer, because of the reduced cardiac output, people can feel dizzy, lightheaded. Some may even, almost pass out. And if they're driving or they're operating heavy machinery, bad things can happen. Now, going back to this slide, like you mentioned, this is a slow pathway, this is the fast pathway. Normal conduction, this is what happens. Everyone, it goes down the fast pathway, it goes from the A to the V. This obviously is the AV node. And in some folks that are susceptible, if you will, to Avnrt, there's a PAC. Okay, so the PAC finds the fast pathway refractory, and it goes down the slow pathway and conducts down here. But just because of the refractoriness, or the lack of it, if you will, it goes back in a retrograde fashion up the fast pathway. Now, again, using the properties and principles in physiology, if the refractoriness, or if the other pathway is still refractory, it's going to stop right there. And this is the basis for the echo beat. I'm guessing you guys understand what an echo beat is. If you don't, there are other slides later in the presentation that talks about an echo beat. But realize this A is normal sinus rhythm, B is the basis for an echo beat, and this is Avnrt. And actually, yeah, right below you have these electrograms that kind of nicely show what I was talking about. So here, this is a PAC that comes before, say, this PAC. And, it's all the ducks in the row, if you will. The PAC conducts down to the B. Fast pathway has completed its refractory period. It's ready to accept the new one. And the PAC goes back in a retrograde fashion. And by the time it reaches here, the slow pathway again has finished its refractoriness, and then that's what sets up this short circuit. And that's what you see on your EKG on an electrogram. So that is the basis of reentry, the refractoriness. That's all you got to remember. When so each pathway has a different refractory period. Once that refractory period is complete, it's ready to accept the next impulse. And once that impulse hits it after the refractory period is complete, then it kind of resets everything. And because of this resetting the mechanism, that's when, all hell breaks loose, for lack of a better term. So this kind of describes the same thing in a more three-dimensional picture, if you will. Honestly, yeah, like I was saying, this is the echo beat. So what is an echo beat? So just to clarify, when we say echo beats, we loosely use it for the AV nodal reentrant echo beats. So there could be atrial echo beats, there could be AVN echo beats, there could be ventricular echo beats. Echo, as the name suggests, it's just a reflection of an impulse, if you will, from a certain area in the heart. The A and the V, the atrial and the ventricular echo beats are not that important. Well, again, I use that term loosely. We don't really, they're not really involved in physiology, or they do not really maintain tachycardias as much as the AV node reentrant echo beats are. So much so that when we say echo beats in today's day and age, we almost always refer to the AV nodal echo beats that we see in Avnrt. So just remember this, there are multiple types of echo beats, but in the EP lab, when an electrophysiologist or whoever is talking about an echo beats, 99% of the times, they're talking about AV nodal echo beats. And like you said, so what is an echo beat? An echo beat is, again, it goes into the physiology of refractoriness. And what happens is that extra beat that happens, it gets conducted in a retrograde fashion. And what it projects on the electrogram, or what it projects on the heart per se, is perceived or is named the echo beat. Again, I know not the not the best explanation, but what you got to realize is an echo beat is just a beat that's coming from the tissue of interest. So like you said, in reentry, you need two pathways. In Avnrt, you do have two pathways. For sake of convenience, they call the slow pathway and the fast pathway. The one thing, though, I would mention in this is for y'all to remember is the fast pathway is located anteriorly and is in the same plane as the compact AV node. The slow pathway is posteriorly. The reason I bring that up is because a lot of times, when we're not getting those junctional beats, and I'll talk about that a little later, when we start ablating, we come on the pedal and we're looking for something known as junctional beats, and we don't get it, or we say that, oh, okay, the pathway is still there. So we try and clock the ablator posteriorly. We go more and more posterior, because by doing that, we're trying to hit some of the slow pathway connections, number one, and number two, we're trying to avoid the AV node. So that's the reason why, if there's a fellow with me, I'll say, okay, you're not getting it there, clock your catheter. So when you're clocking it, you're going more posteriorly. And then that's the reason why, you may hear some of the operators saying, okay, this is not a successful spot, clock the catheter, go a little more posterior, and see if you get it. And that's mainly why. So you get that. Now, so why do we talk the slow pathway? So let's backtrack for a second. When Dr. Jackman, I think he was the first one that started doing this ablation, and then it was Dr. Murati at Michigan, and talking about the late 70s to 80s. And at that point, they were going after the fast pathway, because at that time, they were not aware of the slow pathway. They only thought about, this one pathway, and they thought that was, the main reason people had Avnrt. So they go after the fast pathway, and in some folks, inadvertently, they would, ding the AV node. Some of them would recover, some of them would not. And then, based on the studies and what the papers that we have, the incidence of causing AV block after ablating the fast pathway is as high as 15 to 18%. With regards to the slow pathway, fortunately, it's not as high. In fact, Dr. Murati was like, you should never get heart block. Unfortunately, we're not all good operators as him. I would say that the incidence of getting heart block, despite ablating the slow pathway is still within the realm of 1 to 2%, which is not a small number. So the things that we look for are, when we ablate the slow pathway, you got to maintain the PR, and that's the other thing, y'all will probably hear is, typically in my case, I'll be like, someone watch the rhythm, let me know if the PR prolongs, because the PR is a reflection of the fast pathway. If the PR prolongs, that tells me that the fast pathway is getting dinged, and I come off ablation. But slow, fast pathway, anterior, in line with the AV node, bad choice. Slow pathway, more posterior, maintains normal physiology, probably the best choice. So this is what we call typical Avnrt. The slow fast Avnrt, or the garden variety Avnrt. The Avnrt that, when we see in the lab, it's the few aha moments we have in the EP lab. We're like, okay, this is slow fast, we know what to do, and the success is as high as 95 to 97%, which in our world is as good as it gets. So how do you identify typical Avnrt? All right, so this is what you'll see in the EP lab. I like this slide a lot because that's the way I do it. I put a catheter in the right atrial appendage, one in the his proximal to distal. You've got the CS, and then you've got the RV proximal and distal. This doesn't have both. And this is the ablator at the triangle of Koch. They call it the inferior triangle of Koch. So what I want to get your attention to is there's something known as the slow pathway potential that is nicely illustrated in this. Okay, so this is, the P waves. As you all know, you got the P or the A. This is the his. This is the QRS of the V. So with this catheter, so focus your attention only to the ablator right in the middle of the screen. Here you can see what I call a notched P wave, if you will, but actually it's a slow pathway potential. Truth be told, we don't always see it, but when we see it, again, eyes kind of light up because we're like, okay, this is our area of interest. This is what we need to ablate. And this illustrates, this was just, normal sinus rhythm. And this is what we're trying to illustrate is the fast pathway and the slow pathway working together. Again, if you can direct your attention to the his channel, that's probably a better way to look at it. Though, it's subtle. It's not, it's probably not the best illustration, but what I'm trying to show over here is from the time from the V to the H and the A. Okay. So what I want you to look at is the his channel, and right at the bottom, that's the V. So you have a stem from the V. So look at the column marked FP. That's the fast pathway. Look at the V to H, and then look at here. That's again, you see the stem, see the V to H. That's about the same, and then the H to A is what changes. Again, like I said, you guys hear me? John, can you hear me?
I can hear you. We lost you for a second.
I can hear you now.
Okay. All right. All right. So I'll come back to that in a second. Okay. So this is what we look for. So this is a 12 lead. Typically in the office, this is what I'm looking for. So when I see this, the way I approach this EKG is I call this a narrow QRS complex tachycardia. Okay. So straight off the bat, you've ruled out, SCAR-related VTs or reentry VTs. Of course, there are exceptions to the rule. You could have fascicular VTs that could have a narrow QRS complex. But straight off the bat, when I say this is a regular narrow QRS complex tachycardia, like I said, you've ruled out most of the VTs. You've ruled out atrial fibrillation with aberration. So you've narrowed it down to an SVT without aberration. So you've ruled out an antidromic reciprocating tachycardia. So based on these two terminologies of a regular narrow QRS complex, you'd think you only have three things: Avnrt, ORT, or atrial tachycardia. So the next thing you look for is, always trying to look for the P's. Over here, obviously, really hard. But there are certain channels, if you will, like V1, AVR, and the inferior leads, where you sometimes can see a P wave. And I'm not sure if you've heard of this term called R priming or pseudo S. And if you look at this V1, you see the small peak, if you will, just after the QRS complex. This is, I wish all our EKGs look so good, but this is typical for what we call R priming. When we see this, I mean, I'm like, okay, this is Avnrt, it cannot be anything else. And the reason I say it cannot be anything else is, again, physiological, pretty simple. Think about it. And I'll show you why, but think about it. The time required to go from V to A is almost zero. And in ORTs, where there's a pathway that's connecting from V to A, there will be some amount of time that's required. And of course, I'm talking milliseconds, but it would not be this close. So just looking at this, I know it's not ORT. Well, there'd be some people who would say, okay, this could be an A with a long PR. And I'm like, yeah, that's possible, but you have a T in between. You see that? So what you're saying is that the atrium depolarizes without conducting to the ventricle. And then you have a ventricular repolarization that happens just after atrial depolarization, which makes no sense. I mean, if the atria depolarizes, it's got to send an impulse to the ventricle, unless there's block, which there isn't. But if the ventricle does not depolarize, you cannot have ventricular repolarization. So that rules out atrial tachycardia. Okay, I know a lot of information was shared over there, but hopefully you got the point I'm trying to make. And this is just the same EKG broken down. Compare it to the sinus rhythm. Okay, so let's compare apples to apples. Again, I like this slide. Good job on this, guys. So sinus beat, look at the terminal portion of the QRS, compare it to this. Again, AVF, sinus rhythm. You look at this blip, and that's your P wave right there. Same thing. V1 over here. This is honestly, this is a little, it's a little more subtle than I hoped for, but you get my point. This is what I'm looking for: the pseudo R, or the R priming that we talk of. And in lead 3 and the inferior leads, we talk about pseudo S. But typically, like I said, most of us, we always, when we have an SVT, we always go to the lead V1. Over here, we don't have AVR, but that's another lead. Keep that in mind. And of course, you got the inferior leads, like 2, 3 AVF. Those are really, really helpful. Again, so this is, again, in EP, what I've seen is reinforcement is what helps the most. And so, I mean, I know a lot of these slides look like they're repetitive, but trust me, when you're in your cases and not, this is what will really help you. So again, just walking through sinus beat, have a PAC. So look at the prolongation, so you can appreciate the PR that prolongs here. It goes down the fast pathway, and this is your echo beat, which obviously this is when you see this in an EKG. Again, you have your differentials. The thing about EP is that, like I said, there are always exceptions to the rule. There are always exceptions to exceptions, and there are always differentials. So, of course, if you didn't have this part, the second part of the slide, you would say this could be a PAC, a block PAC. It could be a his refractory extrasystole. Also, that's something that, we don't talk about much. We talk about PACs, we talk about PVCs, but realize this, that the his can also cause refractory beats or extrasystoles. So excuse me, based on this, we don't know for sure. But then moving forward, look at this PR. That's super long. And excuse me. Now it's definitely going in the slow pathway because it's depolarized the ventricle again. You have another echo beat, and over here, boom, it's after the races. And there you've got your Avnrt. So in this case, you've got 1, 2, 3 echo beats, if you will. And so in this case, that's what it took, 3 echo beats. So the endpoint in this patient would be anything less than 3 echo beats, because here it's shown that you need 3 echo beats to start off the Avnrt. So if at the end of ablation, if you're getting 2 echo beats or less, in my book, that is success, because you need 3 echo beats. But that's just one way of looking at success for post-ablation. I'm sure you've all heard of the jump, and what I just showed you is what we call the jump in the EP lab. So it's hard to describe this on a slide when you don't have EGMs. Let me see if we've got maybe for I was looking for the A and H. Yeah, so this probably would help you understand what a jump is. So again, now imagine you guys all scrub helping out in a case. You've got those 4 catheters, and these are only the ones of interest, the HRA and the HIS. Like I said, not everyone. There are a lot of people who do 3 catheter studies where they take out the HRA. Personally, I prefer doing a 4 catheter study where I have something in the right atrium. You have the CS, which will give you the left extension of the left atrium, if you will. You have something in the HIS, and you have something in the V. So like I said, over here in this slide, we're just focusing on the high right atrium and the HIS. So we're stimulating. So the stim 1 is on A, and of course, you're just stimulating HRA in this case. So focus your attention on S1 and S2. Okay, so 600, and then what we're looking for is the AH. Okay. So here you go, you stim in 1, you stim in twice, and then you throw in the stim 2. AH, as you all know, Avnrt has decremental properties, so it will change. So from stim 1 at a drivetrain of 600, you've got an AH of 320. The drivetrain of 320, you've got an AH of 267. So of course, the shorter, when you stimulate something faster, it'll come in sooner. But when I say decrement is as you stim faster and faster, it'll prolong. And I'll show you that in my second slide, or the second column over here. So same thing, 600. Here you've got stim 2 at 310. And like I was talking about, see the 267 is decremented or slowed down to 289, which is typical avnodal decremental physiology. But go to the third one, and then you got a 600, S1 at 600. You got S2 at 300. Okay. But look at AH. You would expect it to decrement some, but it's jumped from 289 to 457. This, by definition, is the jump. So an increase by more than 50 milliseconds when the stim is decrementing by 10. And this is something y'all just have to know stone cold. And you don't need to remember it today, but as you start doing more and more cases, you'll know what I'm talking about. And this is something, I try and drill into my fellows as well. That's a definition. So when the decrement is by 10 and 10 only. So if from 310, if I, dropped it down to say 280 and I saw the same result, by definition, it's not a jump. It could be a jump, but it's not a jump. Not definitively speaking, it's not a jump. But looking at this slide, 310, 300, 289, 457, do the math. That's like 170 or something. And we're looking only for a 50 millisecond change. So this I think is the money shot, if you will, for defining a jump. I don't think you need to look at anything else. If you understand the slide, you understand what AH jump is. And when we see this in the lab, we know, and I'm going one step further, we know the patient has dual node AV physiology. That's important. So a lot of times patients have dual node AV physiology, but not all of them have tachycardia. So let me rephrase that. Everyone with Avnrt will have dual AV node physiology, but not everyone with dual AV node physiology will have Avnrt. Does that make sense? So a lot of times I see this phenomenon happening in the EP lab, but unless we document or induce Avnrt, I personally will not ablate the slow pathway. Any questions?
So, Dr. Mukerji, you wouldn't ablate if you had 2 or 3 echo beats?
Great question, Mike. Not unless there is documented tachycardia. No, I would not. So if this were a patient that is having an EP study just because, I would not do it. But let's face it, when I get a patient to the EP lab, there's a reason, as in there's either SVT documented on maybe the smartwatch or a heart monitor, and the only reason I'm getting them to the EP lab is to identify the SVT. So honestly, to answer your question, I would if there is documented SVT. In fact, there has been a paper, again from Michigan back in the 90s, where they would say that if you've had 2 echo beats or more and you've had documented SVT, you can make a case for ablating the slow pathway. But if I have one of these patients that come in for dizziness or palpitations with no tachycardia documented, and even if I see 2 echo beats and if I don't document Avnrt, the chance of me ablating the slow pathway is highly unlikely. Now, let's be honest. If someone's having 2 or 3 echo beats, they're probably going to have Avnrt. So most likely, I will ablate the slow pathway. So the slide that you're just looking at, this is what we look in. It's the same thing that we talked about right here. This puts things in perspective, and this is what you'll see on your screen, or on the in the EP lab and on the STEM screen while looking at all the EGMs. This is what I'm looking at, if you will. So, like I said, surface EGMs always helpful. High right atrium, the CS, distal to proximal, and then you got the RVA. In this slide, you don't have the ablator, but then it kind of just reinforces what we were just talking about. The stim 1, stim 2, going down the fast, and here in this case, you've got Avnrt. This is what we also call a double fire. So what's happening is that a single stimulus from the A is going down the fast pathway to the B, and it's also going down the slow pathway. And then just because of the timing, you set up Avnrt. So what's really good about the slide, and like I said, for one A, you see 2 Vs. Now, again, it's not so much for y'all, but then this is a question we have in our EP board exams, and it's something that I was filmed a lot on by my attendings, and of course, I do the same to my fellows. It's kind of really neat slide over here, but this again puts everything in perspective as to what we just talked about. Yeah, the catheters we talked about, everyone's different. Personally, I always push for 4 catheters because it gives us more information. And, like I said, in the EP lab, always be prepared for exceptions. Even though it looks and smells like Avnrt, unless you've proven it's Avnrt, you should not be ablating the slow pathway. High right atrium, why do we want it? Tells you about the sinus node. The His, obviously, it tells you about the antegrade, AV node function, conduction, up and down the AV node slow and fast pathways. The CS, it always gives you an idea of what's happening in the left atrium. It tells you if it's a left-sided pathway versus a left-sided extension of an Avnrt. The RV, I always put it in because not only does it help with retrograde AV node conduction, but God forbid if, I ding the AV node, then you got to be patient emergently. And when you have something in the V, that's kind of what will get you out of trouble. So we talked about Avnrt. We talked about recognizing Avnrt. Here we've initiated Avnrt with doubles, as you can see. This is a prototypical EGM of Avnrt. And in the next few slides, I'll talk about, identifying and diagnosing and confirming Avnrt. So the reason I want to talk about this slide is for one simple reason, is that if you look at it, you expect an Avnrt, again, think of it, it's right in the center. Okay, you're talking about Avnrt, you're going up to the A and you're going down to the V. So if something's conducting from the middle, the top and the bottom should all be should be in the same timing on the same line, if you will. So when you see something that's slightly off, a subtle chevron, if you will. Okay, if you look at the start from here and kind of has a subtle chevron and then comes back here. The bottom is the stem, so ignore that. But from the V to the A, so you can see the subtle chevron. The first thing you think of is, is this truly Avnrt? Am I dealing with a left-sided or a septal pathway, or is it something else? The first thing I always tell myself and my fellows is that if your CS is not appropriately placed, or if it's pushed in too much, or it's not, and that can happen because of anatomy and whatnot, then you may have this pattern, or it could be something else. But what I'm trying to tell you guys is that think of simple things first. If it looks like Avnrt, if it smells like Avnrt, the chances of it being Avnrt is higher. So if you're seeing something out of the ordinary, go back to the basics, and something as simple as readjusting the catheter is all that it takes. And again, I've had this happen to me multiple times, that the CS catheter is not appropriately placed, and all I have to do is reposition that, and boom, everything's back to normal. So these are certain maneuvers that we do in the EP lab to confirm the presence of Avnrt or something else. Like I said, when we're talking Avnrt, the only differentials that we're thinking of is ORT, aka Avrt or the pathway, concealed pathway, or atrial tachycardia. So fortunately, we don't have that, but there's something known as entrainment. Maybe, sorry, I apologize for that, guys. I should have checked that. But what I wanted to do is, and I'm sure by this time you guys know what entrainment is. So essentially what we're doing is when we see a tachycardia, we go to a different chamber, if you will, a different spot. So if you're thinking it's Avnrt, you can go to the A or you could go to the V. We prefer going to the V because it's a bigger structure, and when things are bigger, then the information we get is also bigger, if you will, and it kind of again puts things in perspective. So we entrain from the V, and then by entrainment, what we mean is we try to control the tachycardia. So there are two things we look for. One is the number of beats that the catheter requires to entrain, and the second thing is something known as the entrainment response. So think about it again, all physiology. If you have a catheter sitting in the RV apex, and consider a pathway going from the V to the A, when you start stimulating the V, because the pathway, just because of the proximity of the pathway to the catheter is so close, the number of beats required to entrain is pretty small. And again, nothing set in stone, but they say anything less than 5 to 8 beats, the chances of this being a pathway is higher, as opposed to an AV node. So think about the same catheter sitting in the RV apex, but this is Avnrt. So you got to keep stimulating the RV catheter till the stimulated beats, if you will, reaches the AV node. So it's a longer distance, longer time. So the number of beats required to entrain is higher. So if you require more beats, to entrain a tachycardia, the chance of this being AVNRT is higher. Okay. Now, the second response that I look for is the entrainment response. Unfortunately, we don't have it. It's something known as the VAV response versus the VAAV response. John, Mike, have we talked to them about these responses, the entrainment response?
Mike's talking about entrainment.
Okay. So they know. Again, I apologize. I didn't. I should have seen it before. But remember this: when we're talking about VAV response, we rule out atrial tachycardia. Okay, and maybe the next talk I'll spend some more time on these entrainment responses. And just remember this: if it's VAV, it cannot be atrial tachycardia. It rules out atrial tachycardia completely. Okay, so VAV favors or typically AVNRT, excuse me, but it rules out atrial tachycardia. So these maneuvers, like the his PVC, the para his impaced, excuse me, that someone's is on getting a lot of echo. Okay, thank you. So these two maneuvers about the his refractory PVC and the para his pacing. That is not, it's not technically complex. It's not meant to confuse, but I think I want to skip it just because it may confuse more than help at this stage. But when we're talking about ORT, I can compare. So the two things I would want to talk about at a later time is the entrainment response and the use of his refractory PVCs and para his pacing to differentiate between different pathways. And honestly, those two maneuvers are more helpful in pathways than AVNRT. Again, don't get me wrong, it helps rule out a pathway, but typically when you have entrainment, just one maneuver of entrainment, 9 out of 10 times you have your answer there. The his refractory PVC is just to confirm, because in the EP lab, like I've been taught, I've learned, and I teach, is that whatever you do has to be reproducible. If it happens once, you got to do it again, and you got to do it again and again. Reproduce it. It's only then that we can confirm that something is happening. Just a quick 10 seconds on the slide. This is on indications for ablation and whom we should be doing it. Back in the day, yeah, the philosophy or the belief was if someone failed medical management, they should be offered an ablation. But personally, I do this a lot in my practice. If a patient comes in, with all the advanced technologies and access they have to internet and whatnot, if they want an ablation, I don't deny them that. I don't tell them, hey, you know what? These are the indications. You got to try this first. If a patient comes in and tells me, okay, they've got SVT, it's legit, it's documented AVNRT, I'm like, yeah, we'll do an ablation. There's no reason to do medications. Of course, if there are other issues, patient doesn't want an ablation, that's a different story. In my book, I call beta blockers and calcium channel blockers as band-aid therapy. They're not fixing the problem, they're helping it to a certain extent, but as long as that slow and fast pathway are going to conduct it the way they are, they're always going to have AVNRT. Okay, so in typical AVNRT ablations, we always talk about slow pathway ablations. This is what I grew up learning and doing, slow pathway modification. Where I trained, we didn't always necessarily look for complete abolition of the slow pathway. We looked for slow pathway modification, which means at the end of the case, we could have a jump, but as long as there was no tachycardia, we took that as an endpoint. And we had enough studies at my institution where we proved that this was okay. But of course, we always had recurrences and whatnot. So personally, I try and achieve slow pathway ablation, which is a complete absence at the end of the slow pathway. But if it's a difficult ablation, or if I've seen fast junctional beats, or if I've seen a drop beat, in those cases I don't push. So in those cases, even if I have one echo beat or if I have the jump, but if there is no for the tachycardia on isoprel or with 4 extra stimuli, I just stop in the safety and interest of the patient. Because, this is something I learned and I pass it on as well. Unfortunately, in ablation, nothing, it's not irreversible. I'd rather have a failed ablation than deal with a 25-year-old in complete heart block. And I'd rather get that patient again with cryo or something else than live with the fact that I caused complete heart block in that patient. And everyone's different. There are a lot of my colleagues that go on and on about ablating and trying to ablate, and they're successful. And if you come into my cases, if I've been at it for say a couple of hours and I'm not getting it, I'll be like, you know what? Rather than causing damage, permanent damage to this patient, I'd get them back on a different date and try something else. So the key on this slide is this line right here. When you have the ablator or the physician has or her ablator on the slow pathway, the one thing that we depend on y'all is to make sure that there's no His potential, because sometimes the surface EGMs or the catheter EGMs are not the best, or there's noise, or the filtration has changed, or there's something, the gain is off. But on when you're using a three-dimensional mapping system, it's crisper, and sometimes you see the His, and if you do that, obviously your physician will really appreciate it if you tell them that, hey, I can see a His, move your catheter, trust me. This again is from back in the day when we used a lot of fluoro. Today's push is to use less and less of fluoro. But if you were in a lab that still does fluoro, aka my lab, I still do fluoro. Not as much though, but I still do. So this is the 4 catheters I was talking about. They're all, annotated, LAO and RAO. So let's focus on the LAO view. This is about LAO 30. You see the His that, consider a clock. You have the clock face. About 1 o'clock is a His. Got the RV catheter coming in. Got the CS. Now, in my opinion, the ablator, so I'm not sure from where this is, but my opinion, the ablator is a little more anterior. 6 o'clock is where we try to be at, but I would use this spot more for a CTI. For me, I would, on X-ray, this, see where my arrowhead is, or the third dot on the ablator, that's probably where my ablation catheter would be for ablating this in LAO. In RAO, the same, I'm guessing it's the same patient, same time. But here again, this I think is a little more septal. In my case, I'd probably be a touch higher. There's nothing wrong with this. You always start low and move up higher. That's the rule of thumb. Always, like I said, this is more posterior as opposed to this. And this is a little lower, but then this catheter is would probably be over here in my setting. Let me move forward. Okay, so this is the same thing. We're trying to put that into perspective. Same audio picture, and remember, if you recall the slide we just talked about, you see how this is a little higher, closer to the CS, which means it's a little more posterior. Okay, this is the triangle of Koch like we talked about, and focus on B and C. Again, it's so much easier when you're seeing still images. Trust me, I wish we could have this kind of stability in the EP lab, make things so much easier. But this kind of gives you an idea where your catheters need to be at. And the reason I bring this up is because a lot of times, as an operator, I think I know what I am, but I'm not 100% sure. And I, always turn around to my mapper and say, hey, do you think this is a good spot, or do you think this is good? And I always value the input of my mapper. So this is a little more of the same. This is Avnrt, as you can see, as you live and breathe. The ablator, again, audio and LAO images, kind of just giving you an idea of what the catheters are positioned. Now, the only difference in my setup is that When I have my bladder in, I pull out the HRA. So I don't keep the high right atrium because that would mean, 5 catheters, so another stick. So I just, there are some operators that do 5 sticks, like 5 catheters. There are some that do just 3. I stick with 4. So everyone's different. So, you'll see some with just 3, some with 4, and some with 5. So, but it's essentially the same. Okay, so this is what we look for when we come on ablation. We're looking for junctional rhythm, and more importantly, slow junctional rhythm. So when you're measuring the cycle length, when it's 500 or slower, so like 500, 520, 540, 580, that's always a good sign. Why do you see junctional rhythm? Again, if you go back to the anatomy of the slow and the fast pathway, the AV node and the slow and fast pathways going around them, when you apply heat energy, so this is only for ablation. This is not for cryo. So when you do cryo, you do not see junctional rhythm. But when you do ablation, when you apply heat energy to those pathways, the way it amalgamates, if you will, or the way it processes the information of conducting the heat energy is by sending out these junctional, by sending out these junctional beats, because what happens is the slow and the fast pathway, if you will, get stunned, and they kind of, are not refractory, but they just stop, if you will. So we have this junctional escape. Again, I'm using these terms loosely just to explain my point, but we have this junctional escape pathway by which it starts conducting. And when that happens, you've caused damage to the slow pathway. Cryo is not something we use frequently, mainly because we don't have endpoints. The chance of recurrence is higher with cryo. Believe it or not, the chance of heart block is also higher when it happens. But we still have to use it in younger, smaller folks, with really, really compact tissue, where even the slightest movement with the ablation catheter causes AV block. So we still tend to use it, but I would say less than 10% of the time. Endpoints, like I said, the biggest endpoint is inability to reinduce tachycardia. And I'm sure you've seen these cases where we just put in catheters and patients go into SVT. So in those patients, you've done some ablation, and you don't induce tachycardia. I would say, yeah, that's a good endpoint. Loss of dual node AV physiology. That's you don't see the jump anymore. That's a great endpoint. The last two, of course, we never like when that happens. If the PR, and that's the one thing I always look for, if the PR prolongs, that tells you that you've dinged the fast pathway. And of course, if it reaches a point of no return, that's your complete heart block. Those I would not call good endpoints. They are endpoints, of course, but the ones that I personally look for are loss of dual AV node physiology and inability to reinduce tachycardia. This is something that we see a lot in textbooks and also in the EP board exams. I don't know if it's really helpful. It takes, explaining and understanding. I don't know, John, Mike, do you want me to talk about these curves? Let me give it a shot. But what this is trying to explain in form of a graph. So you remember the slide where you saw the stim 1 and stim 2? It's the same slide, but that they put in a graphical form, if you will. So basically what they're saying is that, okay, so just look at the black dots, okay? So you've got A1 to A2, and then you're measuring stim 1 to stim 2, and then you're measuring stim 2 to the his. So you see why it's hard to explain, because if you can't visualize or can't conceptualize the catheters, it's hard to follow the slide. But what they're trying to say is that, when the A1, the stim 1, when the stim 2 is 350, the A to H, okay? So measuring the stim to H is 200. When stim 2 is 400, then the A to H is 150. But when you getting faster. So say at about 350, it jumps out, the A to H jumps out to about 280. So it's basically the concept of the A jump, which they're explaining in this graphical form. And post-ablation, you look at these white circles, and you see that the same stem, S2 at 350, the A to H is, where it should be, and you don't see the jump. Yeah, I don't like the slides. Okay, so yeah, this is what we've started doing. Like you said, when I started doing ablation, we didn't really have much of 3D mapping. We did it on the fluoro X-ray, those catheters, old school. But the 3D mapping helps a lot. So in this, what we do is, that's maybe for the next talk, we'll put in a picture of the slow pathway potential. The slow potentials, what we do is we map the triangle of Koch, and then we identify the slow pathway potentials. We annotate the His, we annotate the CS, we annotate the septal leaflet of the tricuspid valve. And then based on the map, this is, when you're not using X-ray, we go to that area of slope of interest, the slow pathway potential, and then we ablate over there. And then, of course, the endpoints are the same, junctional beats, and then making sure there's no prolongation of PR and no heart block, obviously. Complications, the most dreaded complications, third degree AV block. Sometimes they recover, but it's all about recognizing it, So if the PR prolongs, that's the first indication. You see a PR prolong, you see a fast junctional bleed, fast junctional beat, and that's it. And that's heart block. If you recognize it within the first couple of beats, you may still be lucky. But if it's happened a few seconds into it, like 4 or 5 seconds later, then all bets are off. That's something that we never like happening. So this just kind of, in conclusion, we all know it's a reentry mechanism. You got to have two limbs, the fast limb of the fast pathway, slow limb of the slow pathway. The AH jump is what is significant of dual AV node physiology. It's defined as a change in more than 50 milliseconds when there is a decrement of 10 milliseconds. Medical therapy is available. You have multiple medications, but they don't fix Avnrt. Definitive therapy is always ablation / modification of the slow pathway. And like I said, success is 95 to 90. I almost never say 100%, just because, like I said, there are always exceptions. There are always, hit as much as we may, there are always chances of recurrences. All right, so that was a whirlwind tour of Avnrt. Yeah, well, I was talking for about an hour. Any questions?
I had a quick question about the junctional rhythm that you see after the ablation to prove that
it's during the ablation.
Oh, okay, during the ablation. So once the ablation is complete, that junctional rhythm will go away.
Correct. So yeah, maybe I should spend a little more time there. So typically when we come on ablation, I'm sure you heard that term, you hear the doc saying, okay, let's go on here. When you go on, literally within seconds, what we like to see is slow junctional rhythm. And a lot of times the patient kind of goes in and out of sinus rhythm and slow junctional rhythm, which is always a good sign. Or we stay on that spot for, depending, on whether it's the firstborn or the secondborn, 30 seconds to a minute or even longer. Typically, personally, if I have a good spot, I stay on it for about 60 seconds. Because studies have shown any ablation lesion between 40 or 50 seconds is good enough to cause permanent damage. So that's what we do. The second thing, I almost always use a non-irrigated catheter, a 4 millimeter. But I've seen most of the the kids today. Well, I'm old also. The newer kids that are doing EP, they use an irrigated ablation. The only reason I sort of still stay away from that is because, again, the damage that can happen with an irrigated ablation catheter is much faster and much more permanent. So I think it's just, my training, if you will. But a lot of these newer, EP docs that have just finished training, they use the irrigated catheters, which helps twofold. One is lower power, lower wattage, and lower ablation lesions. Okay. So yeah, I know I answered a couple more questions if there were any, but mainly junctional rhythm, we want it to happen for about 50 to 60 seconds, and then you can come off it. A lot of times, if we get one good burn, 60 seconds, we stop patients back in normal sinus rhythm. Sometimes that's all it takes. And, that's end of procedure. And then we go to testing.
Great. Thank you so much.
You're welcome. Any other questions? John, Mike, comments?
The way I explained it to him, Doc, was I told him that it was very important to write down your stem train and your extra stimulus where you induce the tachycardia. So after you can go right back to that. So after you got a good lesion for a minute, would you go straight to that just to see if you have block there?
Yes, I do that, but I also kind of go through the motions because most times, I'm with a fellow or there's someone with me. Yeah, but if I were on my own, that's exactly, in the interest of time, if I'm doing it in a hospital, yeah, that's exactly what I do. You're right. So yeah, I'm glad you told them that. Yeah, that helps, because just to, continue where you left off, if for some reason you're still having conduction or you still have the jump, then rather than pursuing testing, you're going to go back and do another lesion there, and then come back to test. Yeah, that's an excellent point.
Well, that was excellent. I really appreciate your time, and every time you hear it from a little different perspective, it helps.
Yeah,
And
absolutely. Happy to help. All right.
we'd love to have you again next week if you're up for it. I think atypical flutter would be the topic we'd love to hear you present on if you can.
Yeah, sure. Yeah, and maybe and those will probably add some more images, three-dimensional mapping images, especially with the new catheter, the grid. If I'll try and reach out to Jeremy or someone and have them send me some, excuse me, images from some cool cases. What would really help in those atypical flutters are videos. I don't know if you can get, the maps. You know how PSI does those maps. I'm sure Mike would know what I'm talking about.
I'm sure Jeremy has tons of them. He showed some atrial tach videos yesterday.
For those flutters, especially the mitral flutters and the roof flutters, those maps, those videos help kind of put things in perspective. So that would be really helpful if we could get a hands on those.
I'll get some of the PowerPoints we have onto the shared drive that we set up. And if we get anything else, I'll put it on there. And is this a good time for you next week?
Yeah, we'll just play it by ear because like today I had that one patient that canceled and that's why I could go this time. I'm not sure, my schedule changes from today. So
I'll put you down for 10 o'clock on Thursday and then we'll revisit next week, Wednesday to see where you're at.
good. I'm okay with that.
Okay.
Okay, all right, you guys take care.
Great.
Thank
Thank
you
you
so
very much.
much, Dr. G.
Thanks so much.
Thank you, doctor.
Bye-bye.
Thank you.